water break before the next. What you've had is a very global overview of the problem, and then a descriptor of some of the services that are available. And I guess I'm sort of a great big huge anecdote of how this can actually really work in the environment. Let me set up the pieces of the puzzle here. Wheatridge Internal Medicine, that's my practice. We're internal medicine only. We're the largest non-Kaiser single internal medicine site in the state, and we serve about 15,000 people. We're one of the very few practices that's wide open to Medicare and Medicaid patients. We have about 9 physicians. We have 4 physician assistants and a nurse practitioner, and our visits per hour exceed the local ER. We see, when we're open, in the range of 150 people a day. We're open 6 days a week, and on Saturdays we see about 60 people in the morning. By its very nature, internal medicine tends to bring in very complex patients, and because of I think I live in the epicenter of aging in America, which is Wheatridge. The patients are clearly older, and they're clearly more complex. Next slide. So about 3 years ago, my office manager called me and said, there's this group that wants to meet with you, and my initial response, like all doctors, was, what did I do wrong? And she said, no, this is about what they can do for us. And it was a meeting with Senior Resource Center. And Senior Resource Center has fabulous services available to senior patients. The problem was the location was not necessarily in the place it needed to be at the moment there was a crisis. And elderly people fail medically, but they also fail indirectly due to medical issues. That is a person might fail because they have congestive heart failure and they choose not to take their medicine. But they might fail because they have congestive heart failure and they don't have transportation. So whether I write a prescription and whether they have pharmacy coverage, if they can't get to the pharmacy, pick up the medicine, they're going to fail. And so many failures are not really directly related to medical illness. They're related to the loss of the penumbra of things that independent people need to do to live an independent living. And so SRC's vision was, wow, what if we were actually put an SRC person in your office so when you needed these services or when the patients needed these services, they were there at the time of need, and that's the point behind coupling. Let's go to the next one here. We have an SRC counselor or care navigator who's fundamentally integrated in our office. SRC pays a big part of their salary. Initially, there was a grant that paid the other part of that person's salary, and after the first year, our practice found this service so valuable that we agreed to fund part of that person's salary. We provide the infrastructure, we provide the computers and the scheduling and the time and the ancillary staff, and the SRC provides the invaluable expertise. So patients come into our office, and when they need these services, they can be referred in a variety of ways. The patient can realize that they need assistance to remain in their own environment. Oftentimes it's the family member or the caregiver that realizes that the family member needs help. Sometimes our nursing staff, who has seen a patient over 5 or 6 years, knows that they're beginning to fail, or the patients will interestingly tell the nurses things they would never tell the doctor. My cat died, I spent all my money at the vets, I couldn't take my medicine this month, I know he's going to be mad at me because my diabetes isn't controlled. Their worry is I'm going to be mad about their diabetes, when what I really needed to know was the money was spent at the vet, that sort of thing. So the nurses can refer people. Referrals come through the hospital. If one of our patients gets admitted and is failing, then there's an SRC arm over in the hospital. So any of these pathways can get into the SRC queue in our office. And the SRC individual is no different than any other staff person in our office. They use the same computer, tablet. They're in the same electronic medical record. So their psychosocial database goes in my medical record, and they can look at my medical record and look at the medicines and the illnesses and those kinds of things. So it's integrated. Let's go to the next one. I know we're running out of time here. So services provided, everything that SRC offers in their mothership, you can get through our office. And then there's some very unique things that we've developed. One is a formal cognitive impairment evaluation, and it's very hard to sit down and explain to a patient that they're becoming cognitively impaired. And in many cases, and I'm sure I would too, a second opinion or a formal scoring system is very, very helpful. And so we can literally refer the patients to the SRC counselor. They go through a very well-tested tool and can verify to the individual or their family members that yes, there's cognitive impairment, and it's mild or it's moderate or it's severe. The same intervention usually involves a depression scale to make sure it's not depression masquerading as dementia. There's assistance with end-of-life decisions and documentation of wishes, and I can beat on my medical cohorts. This is something that clearly we need to address with all of our aging population. And the right time to address it is when they're relatively well and in the office, not when they're in the emergency room in extremis. And this is a wonderful service that SRC helps us with. And then finally, there are seniors that are frankly failing, and they lack, because of their cognitive process, they lack the insight that they're failing. In fact, that's the hallmark of dementia, is the lack of insight, the inability to stand outside yourself and troubleshoot your own processes. How did I end up locked out of my house in my slippers at 3 in the morning? You know, that process, that thought process gets lost in the demented individual. And the families are completely bewildered by the legal mechanisms on how they get custody. Not because they want to put mom in a nursing home, but because they want to take charge of the checkbook so mom doesn't spend in the wrong way and use up her resource and end in an environment she doesn't want to end up in. So guardianship can be profoundly helpful, and it's a quagmire to get through that, and in those cases SRC has been unbelievably helpful in helping us do that. Okay, 2 minutes left. Let's keep going. Synergistic responses. The most expensive hospital admission was the one that never needed to happen. And right now, the final common pathway funnel, when the family's in duress and they don't know what to do with their elderly loved one, is they put them in the car and they take them to the emergency room. And the emergency room doctor doesn't have these services, so his final common pathway is he admits the patient to the hospital. And once upstairs, then a social worker or a case manager goes to work, usually the next day. If they come in on a Friday, it's a Monday, they go to work. And this is a tremendous waste of our medical resources, and it's a tragedy to warehouse people in a hospital because there's a perception that they're unsafe. And the key is if you can provide these services acutely when the family needs them, in many cases the person never needed to be admitted in the first place. So one of the things we've been able to do is clearly decrease unnecessary social admissions. Now, sometimes the family needs to hear the message. The two brothers from out of town that think the daughter is doing just fine taking care of mom need to hear that help is needed, that the current living situation is trouble and mom needs more help in the home. And so a unified message is tremendously important. And again, the concept for seniors, going to see the doctor or going out for a physical therapy appointment is a really big deal. And the more services you can centralize in a single location, the easier you make their life. So now instead of going to SRC for home-based care services or coming to my office to see me for medical services, they can come in and we do both at the same time. Last one here. The psychosocial database is tremendously important. SRC puts that information in there. If you know why a person is going to be non-compliant, you can usually overcome that. There's usually a reason that people don't do things that they need to do. People don't wantonly hurt themselves, but there are barriers, and when you know what the barriers are, you can get past them. Hospitalists and emergency room providers now know that they can get this psychosocial database, so they call our office when our person appears in the ER in the middle of the night. In fact, we've made it possible for them with security clearance to hack into our medical record and get information. And then patients consistently report a improved quality